very good evening to all of you. It's a pleasure to be hosting this particular session where Dr. Dayanand is going to walk us through a very interesting invasive fungal infection which he has been able to solve, and his clinical insights on how he went through the diagnosis and management of this particular patient. And that's the gist of what we are going to hear from him. But going forward, is my screen visible?
Yes, ma'am. It's visible.
Yes? Okay. Yes. Thank you all for patiently waiting. Without any further delay, I would like to extend a hearty welcome to all of you for this webinar, because ever since COVID, it has been like, we the only way we've got to do scientific discussions has been, these webinars. And sometimes it comes in really handy, because now if somebody wants to convey a message from Bangalore to somebody in Delhi or Raipur, we have been able to do that. Thanks for the internet for that. So today's we are going to talk about is the detection of invasive fungal infection using infexn, an NGS testing diagnostic test, and it's about a case discussion. So, just a small introduction about Haystack Analytics is we are a health tech based company based out of IIT Mumbai. And we have been working in the field of genomics for quite some time. And infexn is one of our flagship products that has been catering to the infectious disease needs. It has been diversifying, and we've been able to cater to many patients and many doctors. And this is a small introduction about Haystack Analytics. And chief guest speaker is Dr. Dayanand, who's a very well-renowned intensivist, and he has got a lot of accolades. And not just that, from the time I have been interacting with him personally, case on case, when we speak to, he is a very good doctor, and that is one thing I've observed. And he's a very calm and level-headed intensivist, and that's it's a very thoughtful thing about Dr. Dayanand, and he's always very meticulous in how he analyzes the patient, a very scientific way of looking at it. At the same time, he has the empathy of a doctor, and I think that's a terrific combination Dr. Dayanand has. And I am Dr. Shamily, who heads the regional sequencing lab in Bangalore, who's been fortunate enough to have had my hands on infexn NGS technology and being able to cater to these wonderful clinicians in Bangalore and across the country. Dr. Dayanand, he currently he works. He leads a team of intensivists and anesthesiologists at Swastha Hospital, Whitefield. He has had extensive intensive care experience at Sparsh Hospital, Level 3 Trauma Center, and he is from a very standard institute, that is CMC Vellore, postdoctoral fellowship, and he's also, he's worked as a chief intensivist in Swastha Hospital, and he has had uh, an array of experience across the globe. And he is also an American Heart Academy accredited ACLS and BLS provider. And he's also a trained academician. He wants a lot of doctors to learn from this particular case, and that is why Sir is presenting this to the scientific community and the clinician community who have joined today in this webinar. So, over to you, sir.
Thanks, Shamily, for the wonderful introduction. And this is about a lady, an elderly female, 80 years age, who came to us with just fever and productive cough of just one day and breathlessness from the previous evening. So coming to the past medical history, she's a diabetic from 10 years and hypertensive from like 25 to 30 years. And there's no history of any pulmonary diseases like bronchial asthma or tuberculosis. So past surgical history, she had a right shoulder surgery 10 years ago and a hysterectomy about like 30 years. Next slide, please.
Yes.
So coming to the presenting complaints, So she was a moderately built elderly woman. So she was conscious, oriented, and conversant with a pulse rate of 106, BP 120/70, and she was tachypneic with a respiratory rate of 30, but she was afebrile at presentation. The saturations, oxygen saturation in room air was 75% in room air and 95% with 10 liters of oxygen with the Hudson mask. So on examination, she had bilateral bronchi and crepitations in the right infraclavicular as well as intra-axillary areas. So rest of the system examination was normal, and ABG showed a type 2 respiratory failure with a pH of 7.22, PCO2 of 54.5, and PO2 of 98, and a bicarb of 22, lactate of 3.6.
On day one of admission, so the chest X-ray was showing non-homogeneous opacities in the right lower zone, and a total count of 16,920. And she was started on empirical antibiotics with injection piperacillin tazobactam, oseltamivir, bronchodilators, and was also started on NIV, considering that she was tachypneic. So on day 2 of admission, patient was drowsy and dyspneic, but her arousability or sensorium improved on NIV. So with an FiO2 of 60%, 65% and PEEP of 8, she was holding on NIV. And ABG showed worsening PCO2 of like 79.6, a pH of 7.15, PO2 was fine, and bicarb of 28, and lactate had come down to 1.17. But the total counts had increased to 19,730 with 87% neutrophilic. A working diagnosis of acute infective exacerbation of COPD with type 2 respiratory failure and severe PAH was made. And a bronchopneumonia, hypercapnic encephalopathy was made. So antibiotics were escalated to meropenem, and flu and COVID-19 panels were sent. So she started having paroxysmal atrial fibrillation, so requiring amiodarone infusions, steroids for the bronchospasm. So on day 3 and 4 of admission, the total count slightly reduced to 17,890, and PCO2 was still, it came down from 79 to 45, and pH improved from 7.149 to 7.36. She was on CPAP, antibiotics, bronchodilators were continued. On day 4, atrial fibrillation was persistent, and the FiO2 she was requiring 100% with bilateral core scripts in the chest now, and she had like atrial fibrillation with instability as well. So which was not reverting with injection diltiazem as well. So we started her on amiodarone. So but it was not responding. So we started her on diltiazem. And since she was unstable, so electrical DC cardioversion was also done with 50 joules. And she was intubated and an infection panel using NGS, the next generation sequencing. That's what we are talking about today. And was sent. Sputum was also sent for AFB, acid fast basile, and a chest X-ray, again repeat X-ray post-intubation showed non-homogeneous opacities in bilateral upper zones now and mid zones as well. So she was started on NORAD, a single inutro, and a right central line, subclavian line was inserted, and she was put on prone ventilation, sedated, paralyzed, and ventilated. The blood sample, post-intubation, it was the sputum that was sent. Okay, there was a question on what sample was sent for infection panel. It was the sputum post-intubation. Okay. So the patient continued to have fevers and total counts continued to worsen, like from 16,000 to went to 20,000, 22,000 over next 1 week. But the procal was like, still low, less than 0.1. CRP was also not like, very significantly elevated. And the fungal cultures was sent, and 2,3 beta D glucan was also sent. It's a pan fungal marker. So that was also sent for evaluation. And a repeat chest X-ray ultrasound screening showed a right lower lobe pneumonia or the consolidation this time. So she developed critical illness polyneuropathy, a moderate sensory motor axonal peripheral neuropathy on NCS. So, and antibiotics currently were like meropenem, amikacin were going on, that were stopped and started on tigecycline and vancomycin. Vancomycin, considering that, the procalcitonin was less, but the counts were worsening. So we thought we will cover the gram positives. So that's the reason vancomycin was added along with the tigecycline. So over next 2 days, we started empirically on caspofungin. So the total counts were like 28,000, which came down to 25,000 with 92% neutrophilic. And 2,3 beta D glucan, the pan fungal marker, was slightly elevated. So normal is like 0.06. It was 0.22 in her case. And the bronchoscopy was done at this time, and the bronchoalveolar lavage was planned, and it was taken. And the sample was again this time sent for an infection panel. So this was the infection panel that was sent initially. If you see the data, it was sent on 7th. That is like 3 days post admission, 7th of November. So that did not show any infections. So, but later the sputum that was sent had grown like Klebsiella. Next slide, please, ma'am. So total count came down on day 6 to 9,900, but persistent chest symptoms were there. As I said, ET culture had grown Klebsiella, which was sensitive to carbapenem, tigecycline, amikacin, and Bactrim or Septran. So blood cultures, there was no growth in the blood cultures. Patient requiring small dose of iron drops. Next slide, please. So she had a doubtful seizure on one of the nights. So she was started on given injection lorazepam and Levipil. So tachycardia and fever still persistent. On day 8, persistent fever, empirical fluconazole was started before the caspofungin. So you saw that day 10 and 11, we started caspofungin. Before that, fluconazole was empirically started. So this was, I think, day 11, as I said. So you can see the the extended spectrum to cover the yeast and molds and the dimorphics. So based on this, caspofungin was started to cover which has a very broad spectrum antifungal effect. Next. So and the second BAL fluid that was sent showed Fusarium, Stenotrophomonas, and Pseudomonas. 3 organisms were identified on this. So the Fusarium, which Dr. Shamily will be talking about, as is inherently resistant, and even the Stenotrophomonas, it's inherently resistant to carbapenems. So that's the reason why we changed to tigecycline and other antibiotics. Next slide, please. So the blood and the plasma samples that initially we said, did not show any organism. So we were suspecting whether this Fusarium was whether it was really present in the lung, or is it a contaminant, or is it causing a invasive fungal infection. So that's the reason why we sent a blood sample as well. But blood sample turned out to be negative, so suggesting it's a localized pulmonary infection. Next slide, please. So further, now the antibiotic meropenem, Bactrim, Linid, as well as caspofungin were going on. So patient came down to have a minimum ventilator support like FiO2 of 30%, PEEP of 6. But she was weak generally, like she had polyneuropathy, and considering that she requiring a prolonged ventilator support and hospital stay, a spontaneous breathing trial was done, which she failed. So she was taken up for a surgical tracheostomy. So usually tracheostomy, there was no significant difference in case of an early or delayed tracheostomy. The only thing is like in cases like reversible causes, like where it's a pneumonia and all, we tend to go for a delayed tracheostomy. So like in patients with severe head injury, head trauma, where you're expecting them to come back later, so expecting a prolonged ICU stay or prolonged ventilator stay, that is when you may consider for a earlier tracheostomy. So considering that the Fusarium had come positive, so we changed the caspofungin to tablet oriconazole, which is economical for the patient as well. So over next 1 week, tracheostomy was closed and patient was able to speak, and she was put on 6 weeks of oriconazole, and she was shifted to ward. Counts reduced, and day 28 she was afebrile and saw soft diet. So on 29 days, so she was discharged from the hospital. So this is about the patient scenario we wanted to talk about. So now we can go for the discussion on the fungal infections in the ICU. It's a well-documented complication, considering that patients will have a prolonged stay, sometimes, non-resolving pneumonias, critical illness polyneuropathies, patients on dialysis requiring a lot of, interventions with multiple invasive lines, like, procedures like in lines, tubes, catheters, use of broad-spectrum antibiotics. These all lead to increased risk of fungal infections in the ICU setup. So as well as the patients will be, immunosuppressed transplantation patients, post-transplantation, or seropositive patients, and who are already on malignancies, diagnosed with malignancies, on treatments, chemotherapy. So these are all lead to increased risk of the fungal infections. So the fungal infections are attributed to around 20 to 40% of mortality in ICU patients. So coming to the classification of the pathological fungi in the classification, so basically we classify them into yeasts and molds based on the anatomic morphology. So yeasts include Candida, Trichosporon, Cryptococcus, and Rhodotorlas. So the molds include aseptate hyphae and septate hyphae. In aseptate hyphae, we include like zygomycetes and the mucormycosis, which was notorious during the COVID and other infections. And septate hyphae is again divided into dimorphics, opportunists, and dermatophytes. In dimorphics, there are like histoplasma, blastomyces, coccidioidomyces, and penicilliums. So the opportunists include Aspergillus, Scedosporum, and Fusarium. So dermatophytes again include Trichophyton and the Microsporum. So coming to the Candida speciation, Candida basically again divided into Candida albicans and non-albicans. So most common is the around 40 to 50% of the infections in an ICU will be by the Candida albicans. So it's most commonly isolated and causes invasive candidiasis. So, and in non-Candida albicans, Candida non-albicans, so Candida glabrata, tropicalis, Candida parasilosis, cruzi, and lusitania will be there. So Candida glabrata, it has one of the highest mortality rates if the patient gets this infection, and it shows some resistance to the azoles, like especially the fluconazole. So Candida glabrata and tropicalis are responsible for another 20 to 30% of the cases. So tropicalis is widely susceptible to all the available antifungals. So more important in Indian scenarios. So Candida parasilosis is responsible for around 10 to 20% of cases, and it's a common nosocomial infection. So it's associated with usually plastics like IV cannula, TPN, central lines, and it is a less virulent species. So in less than 15% of the cases include Candida krusei and Lusitania. The krusei is intrinsically resistant to the fluconazole, but it is sensitive to the voriconazole. And Lusitania, it is intrinsically resistant to amphotericin B also. Okay. So coming to the molds, invasive aspergillosis is one of the significant infections, primarily affecting the immunocompromised transplant recipients, like hematological malignancies and severe neutropenic patients. Rarely it can happen in non-immunocompromised ICU patients as well. So like patients with chronic lung disease or severe liver failure patients. So other molds include like zygomycetes, fusarium, and scedosporiums. So these commonly cause nosocomial outbreaks. So basically from aerosolized spores, like from construction contaminants and contaminated medical products like equipments and even the hand lotions or the sanitizers. The commonest route of infection is like lungs and sinuses. So it can also affect the skin and CNS. So bloodstream infections rarely occur. So coming to the diagnosis, the advances in the diagnosis of these fungal infections, there are traditional methods which we commonly use, like clinical evaluation, direct demonstration, like smears, KOH preparations, cultures, and the radiological evidences and the histopathologies. So coming to the clinical evaluation, like how you evaluate or how you suspect the fungal infections clinically is, by risk factor for invasive fungal infections. You suspect when patients have these risk factors, like immunosuppressed patients or in intensive care patient. It's like, patient who is on a central venous catheter for some time, patient who is on TPN, patient who is already on broad spectrum antibiotics. Because until you get something positive in your blood cultures, so you will be putting them on the broad spectrum antibiotics. So on the high Apache scores, and patients on acute renal failure, particularly if requiring hemodialysis, and if the patients had prior surgery, particularly the abdominal surgeries or GI tract perforations and anastomotic leaks. So again, Candida's, the other methods are like, calculating the Candida score. So it's a bedside scoring system where you can suspect early antifungal infections and start early antifungal treatment in patients who are not even symptomatic for the fungal infections. Like patient where you give scores for, like, patient who is already on TPN, you give a score of 1. Patient who had undergone a surgery recently, give a score of, within last 7 days, give a score of 1. And multifocal colonization. So you take swabs from multiple places like nasopharynx, esophagus, or the ET aspirate, and throat, or even from the gastric aspirates. So, and if any positivity is there, you give a score of 1. And the clinically severe sepsis, patients who are clinically severely septic, you give a score of 2. The cutoff value is taken as 2.5. So somebody who has a score of more than 2.5 has a high risk of the high sensitivity of, like, 81% positivity rate and specificity of 74% for a fungal infection. So the person who has a score of more than 2.5 is said to have a 7.75 times more risk of proven fungal infection or the candidiasis. So you can use this the table or the flow chart, so to assess the risk in the clinical assessment of the colonization index, where you take swabs, as I said, from multiple sites, and number of positivity or the positive swabs divided by total number of swabs taken. So on every 3 days or so, you can take for 2 weeks continuously. And if the score is like more than 0.5, there is a high risk of a fungal infection, patient developing fungal infection. As I just mentioned, the Candida scores. So you can use these predictive scores, and you can try to start the empirical antifungal treatment even before patient develops any symptoms of a fungal infection. So usually so the predictive rule is like, somebody who's in ICU stay for more than 4 days, and who is septic, has a central line, who is on a mechanical ventilation, or plus one of these factors, like, patient who is on TPN, dialysis, major surgery within 7 days, as I said, or a pancreatitis, or on immunosuppressants or steroids. So these are the high-risk candidates for a fungal infection, in whom we can empirically start on the antifungal therapy. Next slide. Yeah. So coming to the limitations of these traditional methods, like, direct demonstration has a very low sensitivity, and cultures reliable when there is a fungemia. Cultures may not come positive, like blood cultures and all may not come positive unless there is a fungemia. The fungus is in the blood. And the problem mainly is with the delays. Normal incubation period is like 4 weeks. The results may come after 6 weeks. By then, if the antifungals are not started, patient is not going to wait such a long time. So, and radiographic evidence, like, depends upon the host immunity, how the things develop in a CT or imaging studies. Histopathology, again, you'll have to, invasive procedure where you go in and take the sample, like, when you do a bronchoscopy, so even bronchoalveolar lavage may not be able to pick up the sample unless, you take a sample from the, if the nodules are in the periphery, you may not be able to pick up the proper sample. So you may have to do a transbronchial lung biopsy or a biopsy of the nodes itself. Coming to the newer methods, like where you can go for the galactoman So galactomannan is highly sensitive and specific for the aspergillosis. So it cannot detect other fungal infections. So there's other samples where you can, it can be sent from the blood sample serum or the bronchoalveolar lavage. Other areas like, CSF, urine and other body fluids can also be sent for the galactomannan assays. Limitations are like, false positivity is there if there is a concomitant beta-lactam usage. So you need to use a higher cutoff value when the patient is on a beta-lactam antibiotic. And there are issues with, false negatives if the patient is already on prior antifungal use, like, patients who are on transplant patients, so who may be already put on antifungal prophylaxis. And in patients with non-neutropenic patients. And others like, Candida mannan antigen and Candida anti-mannan antibodies can also be checked to suspect the fungemia. So other markers like, beta-D-glucan, which we have done in this patient, is a pan-fungal marker. So it is very non-specific, but it is highly sensitive. So it has a high negative predictive value. If the values is less, you can easily rule out at least, saying that, it can be a fungal infection. It may not be a fungal infection. So because the confusion with the current case, what we had is like she persistently had higher counts, but the procalcitonin was still less. So usually in common thing in Indian scenario is like we commonly see the gram-negative infections where, the procalcitonin would also be going high. So we can see that there will be extremities. So we have to rule out even, you cannot depend on the one value of a, procalcitonin. So as we said, if it is elevated, so it may point towards the, gram-negative sepsis. But, like just example of this patient, negative value is doesn't rule out an infection. So as I said, the beta-D-glucan has a high negative predictive value, and it can detect all fungi except Candida and including Candida and Aspergillus, but not the Cryptococcus or the Zygomycetes. That we'll have to keep in mind. Though we say it as a pan-fungal marker, Cryptococcus and Zygomycetes may not be detected. So we can use this, in prospective ICU monitoring, like for a 1 to 2 weekly, and identify who needs further diagnostic workup. If the values are elevated, it means patient is developing a fungal infection, and you need to evaluate further to localize where the infection may be. Is it chest, urine, or other parts? So earlier the initiation of antifungal before the clinical symptoms can start. So we can predict that the patient is developing a fungal infection and start the antifungals. Again, limitations of this beta-D-glucan is a false positive, common in, if you do a single test. As I said, you need to do a series of tests to predict really. When you do multiple series of tests, that is when the sensitivity improve for this test. So especially false positive can come in patients who are already on dialysis. So as I said, more than one sample is recommended to improve the specificity of the test. So other newer methods like, matrix assisted laser desorption ionization, time of flight mass spectrometry. So it's a very rapid test where within 30 minutes it can be done from the cultures. So, and it's useful for the yeast, but it's difficult to identify the modes in this test. And other PCR based assays are there. So please come. And the current, the last and final test is like where even the American Society of Infectious Diseases recommends to go for the molecular testing. One of them is this NGS, or the new generation sequencing, new gen sequencing we call that. So all these years, the non-availability was a major problem in our Indian scenario, thanks to Haystack. So they have brought this test so that we can get our reports very early rather than waiting for 4 weeks or 6 weeks for the fungal cultures to come positive. So as I said, the advantages of this testing is like results are available within 24 hours, whereas the cultures take more than 4 to 6 weeks, and you can detect the resistant genes. So for the specific antifungals, so this helps guide us for an appropriate antifungal therapy. So regarding this gene sequencing and the Fusarium bacteria, the fungus that we got in the positive in this test. So I think Dr. Shamily can give us some information over these things. Thank you, Shamily. And she's being a microbiologist heading the team. So I think she can give more information on further slides.
Thank you, sir. So there was it was an excellent presentation because you not only took us through the clinical case, you also gave us a snapshot of how much diagnostics is accessible to a clinician, and where a clinician draws line and what is needed in in your field of practice. And thank you so much, sir. It was a wonderful session. I would just like to touch base upon a few things about the organism. Fusarium, as such, is a demeticious mold which can grow easily and rapidly on different media. This is just an overview, a microbiological overview, and the colonies around Velvety to Cottony. There are multiple species complex that are being detected these days, and the time for it to grow can vary any day between 48 hours to 7 days, sometimes extending even more than that. And on microscopic morphology, that is the LPCB that has been a picture has been taken up from invasive fusariosis, which is a CMR article that is available on ASM journal. It can show a banana-shaped macroconidia. This is very peculiar about fusarium. And sometimes we do consider fusarium as a contaminant in traditional culture methods, but it is always the clinician who gives us the information that, whether to consider this as a contaminant or not. So having said that, what are the common you know from a very basic microbiology point of view, what are the diagnostic challenges a microbiologist faces is that most of it need special media, a proper incubation condition, a lab setup, dedicated technician, and sometimes these certain molds can be so difficult to even sporulate, and a lot of their identification relies upon the microbiologist's skill and their experience and expertise in interpreting these molds and what they are. And the problem with automated identification that is available is that it cannot identify all the yeasts. So perhaps with Candida, even now, sometimes people who have used, certain systems will know that certain yeasts are kind of a trigger to know, for example, Cryptococcus lawrenci, identifying repeatedly in a particular system. You might be wondering whether it is actually Cryptococcus or not. So this, the level of identification, genus, species level of identification, it narrows down, and it is accessible only in certain centers or referral centers. And even to identify dimorphic mold or demeticious molds, or there are certain uncultivable fungi like pneumocystis. So the availability of microbiological tests that I can give to any clinician who requests me, listen, I have a patient, I need to diagnose this. So it becomes very constrained. It becomes a very constraining affair to a microbiologist. And the time to identification, certain yeasts will take 48 hours, sometimes even lesser than that, but sometimes for certain molds, like for this particular case, fusarium. So in a traditional setup where a sputum culture or a ball culture is being put on blood agar, chocolate agar, and McConkey, and we streak and we wait. We need special incubatory conditions. If we even streak it on SDA, so it would still take me 48 to say that a mold is growing to the clinician, or to even do a critical reporting to the doctor. So the doctor has to, by and large, the clinician has to cover in a wide array or a broad spectrum antifungal to, for that emergency report that I give him. Now, when we speak about next generation technology, where we are doing targeted sequencing using infexn test, it gives a full species identification. So for that matter, this Fusarium succinatum. So it was directly from the sample and within 24 hours. So this was a valuable piece of information which not only correlated with the clinician's suspicion that he had an early suspicion that something was off. Procal is low, counts are high, patient has all the risk factors for an invasive fungal disease. So I think he was almost right that it was a fungal infection. But to give sir the right, sir, you were right, let me give you the right answer to it. So that we were able to provide him with that thanks to this technology. And the best part about this is the identification of yeast, mold, even the uncultivable ones, because it's a targeted sequencing based test. So we are being able to identify all of this without the additional requirement for any, the conventional method. So even a resource poor laboratory can still outsource this particular test and provide an answer for their clinician. So that is the scalability of this particular test. And as we have all told, this is a targeted next generation sequencing based diagnostic test for infectious disease. It is directly from the sample. So there is no culture enrichment process that is involved. So there is no hypothesis that let me think of aerobes, let me think of anaerobes, let me think of fungi. No, that is not there. It is pan bacterial, pan fungal, and we have also included respiratory viruses and neuropathic viruses, and 9 therapeutically relevant antimicrobial resistant genes. And it is sample agnostic except for a few, which I will just touch based on. It's a single test solution, and there's a proprietary automated software that churns out these results, and it has been validated, and it is due to get registered now. And these are the samples that have been accepted, except for stool, sputum, superficial wound swabs, and patient collected urine. This is by and large to reduce the commensal background, the background noise, which might not always give you a right answer to the clinician. And yes, since it's a highly sensitive test, the transport conditions and the sample collection has to be ensured. I think sir has made sure of it uh, in all his samples from day one. That is one thing I can definitely tell, because the way sir collects the patient samples, I have not seen a background noise of commensal flora. So I'm very happy, because even in in culture we will be able to pick out the contaminants or commensals of a higher degree, but the sample collection is immaculate when it comes to what we have to put into this particular test. And yes, I personally believe that next generation sequencing is the future of infectious disease diagnostics, provided the context, the clinical context is taken into account, and the right sample is taken, and a proper dialogue between the clinician and the doctor is established, and a good diagnosis is given to the diagnostic to the clinician, so that he can take the right decision for his patient. So thank you all. Thank you, sir.